Good evening, respected professors, seniors, and dear colleagues. A warm welcome to one and all for joining us on a Sunday evening. As a part of our ongoing monthly CME meeting, we are pleased and honored to have a teacher of teachers, Professor Jacob Thomas, coordinating today's webinar on acne and acne-form eruption. His knowledge of clinical dermatology is unmatchable. And as a student, I have witnessed it and benefited a lot from his teachings. We thank you, sir, for this. And we also thank Professor Johannes Deirit for accepting and joining us today to talk on mask acne, and Professor Parimalam for readily accepting our invitation to talk on acneiform eruptions. Our sincere, heartfelt thanks to our beloved chairpersons, Professor Parveen and Professor U.R. Dhanalakshmi, for chairing the session. Without much further ado, I hand over the stage to Professor Jayakar Thomas. Over to you, sir.
Thank you very much, Dr. Maya. Seemed very kind of you, indeed, to have invited me to conduct this CME program today. And kinda has been my good friend, Dr. Johannes Dairy from Manila. Been knowing each other for a good number of years, been meeting each other in India, outside India, in Philippines itself, from where he comes. A very popular man in Manila, in the Philippines. He's been well qualified with several fellowships and done a lot of work in surgery with a number of publications in international journals, local journals, and he's been awarded different awards and scholarships. A Galadari Award, you know Professor Galadari from the UAE, European Academy of Dermatology Fellowship, the International Society of Dermatology Scholarship, on two occasions, 2007 for Argentina and 2009 for the Prague International Congress of Dermatology. So with this type of background, I will request Dr. Johannes Dairy to make his presentation on maskne. This is something new which has come up recently with the pandemic of the COVID-19. Dr. Johannes, the stage is yours.
All right, thank you very much, Prof. May I now share my slides and my screen? Right, can you see my slides?
Yes.
All right. So thank you very much again, Professor Jayakar Thomas, Dr. Maya, for the invitation. And I was given the task to lecture on the topic maskne, which is fairly new, very few publications, and most of the reports are from the news, from letters to the journals. And we have been seeing cases of maskne fairly recently during the COVID-19 pandemic. So it's nice to share insights on some of my observations and do a short research on what has been published on some related conditions such as acne mechanica. So good evening. So my name is Dr. Johannes Dairit. I work at the De La Salle Medical and Health Sciences Institute, which is a university hospital, and at the Research Institute for Tropical Medicine in Manila. So what exactly is maskne? So maskne is definitely real. It is not an imaginary skin condition, and it involves mainly health workers and frontliners. It is a form of what has been described in the past as acne mechanica, and the incidence has increased during the COVID-19 pandemic, at least anecdotally. Stress and local irritation from wearing face masks are contributory factors. Maskne has been equated with a disease which has been described way back 1975 called acne mechanica. And acne mechanica has been described in the textbook by Zoe Dreylos as inflammatory papules and pustules secondary to friction from repetitive rubbing, stretching, or squeezing of the skin, and triggered by heat, pressure, and occlusion. It is actually a form of sports-associated dermatosis. However, in 1983, Albert um, Kligman's conclusion was that acne mechanica is a form of contact dermatitis from physical stressors. So this was the first publication on acne mechanica in 1995 by Dr. Mills and Dr. Kligman, published in the archives of dermatology. So in the article, they described acne mechanica as local exacerbations of a pre-existing skin condition such as acne, rosacea, or perioral dermatitis. It is secondary to pressure, friction, rubbing, squeezing, and stretching. And the acne-form eruption actually appears underneath tight straps and belts, football, shoulder pads, or the rubbing of the back in bus drivers. Albert Kligman was saying that if you seal acne-bearing skin under adhesive for 2 weeks, it would induce the formation of inflammatory lesions from microcomedones. Some of them are not actually seen by the naked eye. In 1976, another publication came out in the British Medical Journal by Dr. Tan involving 12 patients. So this was actually a case series, and 9 of them presented with acne on the back. And 9 of these patients were actually hospitalized for orthopedic procedures. And 3 of the patients developed perioral dermatitis after splinting of the teeth, which we now call brackets. All patients had a previous history of mild acne, and the lesions were both inflammatory, so pustules, papules, nodules, and cysts, as well as non-inflammatory lesions such as blackheads and whiteheads, or open and closed comedones. The main differential diagnosis in the case series was folliculitis. However, the lesions were observed to be more pleomorphic. They were deeper. So some of them are actually nodules. And the authors observed that the eruption usually fails to respond to topical treatment or the topical antiseptic chlorhexidine. And long-term tetracycline treatment is often required for resolution. And the proposed pathophysiology is most probably stasis of oil secretions or sebum, which promotes P. acne colonization. So what's the science behind maskne? So this recent report was released by the Cleveland Clinic Foundation. So wearing a mask actually causes trapping of hot air and creates a humid environment. And this causes proliferation of yeast, bacteria, and Demodex mites, which promotes an exacerbation of the following skin conditions, such as acne, rosacea, and perioral dermatitis. Another research letter was published in May of 2020, which described skin damage among healthcare workers managing coronavirus disease in 2019. So this was written by our Chinese colleagues. And in the article, the face is most commonly affected, the most commonly affected site of damage during the COVID-19 pandemic. So this is from the Hubei province. So the prevalence rate of skin damage was 97%, and predisposing factors include wearing of N95 masks, more than goggles, more than face shield, and more than aggressive hand hygiene, such as washing the hands or application of antiseptics such as alcohol. And 83% of healthcare workers in Hubei in China suffered skin problems located on the face, which involved the nasal bridge in 83.1% of cases, the hands as hand dermatitis in 74.5% of cases, the cheeks, followed by the forehead. And the conclusion of the letter to the editor was that wearing of medical devices such as masks more than 6 hours had higher risk of skin damage. Anecdotally, an increased flare-up of acne and acne-form eruptions were also seen outside of the hospital or outside of healthcare. So these are some data from my private clinic. These are the most common diseases which required face-to-face consultation during what was called enhanced community quarantine, which is the more strict quarantine measures implemented in the Philippines from March 14 to May 10. And the most common reason for urgent consultation was number one, atopic dermatitis, followed by acne vulgaris, infections in 16% of cases, rosacea, followed by psoriasis, and 9% of the patients came in the clinic for cosmetic reasons. However, for teledermatology, this is just an overview of telemedicine consultations in my private clinic during this time from March to May of 2020. So acne vulgaris was at the top of the list, followed by atopic dermatitis and then rosacea. However, you will notice a change from May 22 when the enhanced community quarantine was replaced by the less strict general community quarantine from May 22 to October 22 of 2020. So I had a total of 1,240 face-to-face consultations. And during this time, we can see that 5% of the cases uh, in which the diagnosis was what is called maskne. So this data has been generated by a computer program which was actually invented by an Indian. So it's called Clinacea. So I will share to you the case series. These are actually cases of maskne among Filipino patients in my private clinic, seen from May 22 to October 22 of 2020. So for the methodology, all of the patients came in with the chief complaint of pimples due to prolonged wearing of masks. So I did a comprehensive history taking, physical and dermatological examination, chart review, and a case assessment form. 3D photographs at baseline were taken as well as every 2 weeks follow-up. So most of the, and all the 30 patients had at least 3 follow-ups from May to October 2020. So this is the case assessment form that I filled up while doing an interview and physical examination on the patient. So I tried to extract the data, personal data, previous diagnosis, for example, acne, rosacea, perioral dermatitis, atopic dermatitis, psoriasis, etc. Type of skin lesions, whether non-inflammatory, open or closed comedones, and inflammatory lesions, such as papules, pustules, nodules, and cystic lesions. Sites of involvement on the face, whether it's on the forehead, the temporal area, the nasolabial folds, the malar area, zygomatic, chin, mandibular area, or extending to the neck. So I also noted the onset and duration of lesions and the type of masks used and whether the patient had self-medication prior to consultation at the clinic. And photographic assessment was done on all patients using a three-dimensional standardized medical imaging, using the equipment Quantificare LifeVis Mini. So I also used certain apps such as the detection of redness app for rosacea. So for the results of the case series, 30 patients actually qualified for the case series in which 24 were females and 6 were males. The age ranged from 14 to 46 years old, and the mean age was 28.5. The onset and duration was from 2 weeks to 4 months, with a mean duration of 6 weeks from the onset. So the 30 patients involved 3 healthcare workers. So all of them are nurses in the COVID wards. 25 were factory and office workers, and there were 2 teenagers. And all of them wore masks, 8 to 10 hours a day, at least 5 for 5 working days. And these were the identified causes of acne and their corresponding percentages. So At the top of the list is rosacea involving 9 patients, 32%. Pityrosporum or yeast folliculitis in 7 patients, which is actually 25%. Acne vulgaris in only 6 patients, probably because there were very few teenagers who came to the clinic because they're not allowed to go out. So patients less than 18 years old are not actually allowed to, are still in quarantine. 5 patients had underlying perioral dermatitis, comprising 18% of cases, and 1 patient had a severe flare of seborrheic dermatitis. For the type of mask used, 67% used surgical mask, 23% used cloth masks, and only 10%. So mostly the healthcare workers used the N95 mask. For the systemic therapy that has been given to the patient. So 11 were given limecycline, 10% were given isotretinoin, 7 patients were given itraconazole, 3 patients were given doxycycline, 3 patients were given azithromycin, and 2 patients were given betamethasone loratadine, especially to take care of the allergic reaction. For the topical medications, these were given clindamycin phosphate solution, 1%, metronidazole cream, 0.75%, fluconazole and miconazole cream in 7 cases, and a combination of triamcinolone and miconazole cream in 5 patients. And these were the identified underlying causes of acne. At the top of the list is rosacea, which is followed by yeast or Pityrosporum folliculitis, followed by acne vulgaris, then perioral dermatitis, and seborrheic dermatitis. So just to review very quickly, this underlying diseases, rosacea is transient. It is characterized by uniform papules and or pustules. And it is also characterized by persistent central facial and perilesional erythema. If you look closely, especially if you use dermoscopy, you'll be able to appreciate the visible red blood cells, red blood vessels or telangiectasias. Um, some very prominent symptoms include and signs include edema, stinging, and burning. It is more common in middle-aged women from 35 to 45 years old. And most of the lesions occupy the central third of the face, the cheek, the nose, the chin, and the central forehead. Let us all be reminded that the classification has been revised in 2018 from an article in the JAD in January. So the National Rosacea Society Expert Committee revised the classification and revised the classification of rosacea and advises dermatologists to characterize the rosacea in their specific phenotypes. So only one a diagnostic phenotype is required to make a diagnosis of rosacea, and either the patient has persistent centrofacial erythema or just phyma. So either um, each of these features classifies a patient as having a rosacea. For the major phenotypes, any two of the phenotypes are required. So it's either transient facial erythema and a combination of inflammatory papules and pustules, telangiectasias, and ocular features. However, we have to take note that telangiectasias occurring solely on the uh, alanaceae um, is fairly common in patients at the age of 40 and above. The secondary phenotypes include burning, erythema, edema, and dryness. So if you are um, more keen on doing dermoscopy on your rosacea patient just to differentiate it from other skin conditions, you will see brown yellowish structureless areas, some linear vessels in polygonal pattern, dilated hair follicles, follicular plug, ill-defined white rosettes, and non-specific scaling. For in some cases in which the diagnosis can be like controversial, or there are issues whether there are other differential diagnoses, we can do a biopsy, and basically you will see telangiectasia of blood vessels, and an inflammatory infiltrate surrounding the hair follicles and the sebaceous glands. And you may also see lysis of the and hypertrophy of the sebaceous lobules. We'll be more specific with the treatment, especially the ones that I've used in the 30 cases. So for rosacea, we recommend low dose isotretinoin. So we use a lower dose of zero point 0.1 to zero point 0.5 milligrams per kilogram per day of isotretinoin. Limecycline at 450 milligrams per day. So the usual dose of limecycline available in the market is just 300 milligrams. So we can give it like twice a day. Doxycycline at 50 to 100 milligrams per day. In the Philippines, the 50 milligrams is not yet available in the market. Topical medications include azelaic acid. However, I would personally recommend metronidazole, 0.75% cream or gel. And studies have revealed that there is improvement in the appearance of inflammatory lesions with the use of the metronidazole 0.75% gel applied twice daily, um, which may occur as early as 2 to 4 weeks of therapy. However, you will see very good results if you extend the treatment to 8 to 9 weeks. So this is just another study published in the Australian Journal of Dermatology in 2016, um, recommending the use of very low dose isotretinoin in mild to moderate papulopustular rosacea in a review of 52 patients. So the dose is as low as zero point 0.1 to zero point 0.5. So that means giving the patient 10 to 20 milligrams per day of isotretinoin and further tapering it down to, for example, 10 milligrams every other day or twice or just twice a week, depending on the clinical response. So for the outcome of the study, 91% or 42 over 46 patients, their rosacea have cleared or the response was excellent. And the only side effect noted was cheilitis in 51%. So the conclusion of the study is that very low dose isotretinoin, so 10 to 20 milligrams once to 5 times a week, equivalent to 5 milligrams per day, is an effective treatment for mild to moderate papulopustular rosacea and is very well tolerated. So these are just some cases from the case series in my clinic. So this is case number 11 and case number 12. So these are my patients who have been diagnosed with rosacea in the past. They are doing pretty well until they started wearing face masks for prolonged hours. So one works in a factory and the patient on the right works in the bank. So they are required to wear masks for 8 to 10 hours. And this is case number 24, a 27-year-old female with nodules and cysts on the nose, as well as papules, pustules, more prominent on the chin. You will also observe a certain degree of rhinophyma and metaphyma, or enlargement of the chin. So I gave the patient low-dose isotretinoin plus azithromycin 500 milligrams 3 times a week, and topical metronidazole. So this was after 1 month of this, or before and after photos after 1 month of treatment. And you will see that there is persistent centrofacial redness. So this is in fact a case of maskne with underlying rosacea. I would also like to mention a condition which is definitely related to rosacea, which is the more fulminant or more severe form. So this is rosacea fulminans, which is characterized by papulopustules, purplish nodules, as well as abscesses. And usually the nodules form confluent fistula that drain a serous or a mucus discharge. It occurs fairly common in post-adolescent women, so 20 to 30 years old. It is more common among pregnant women. However, compared to the nodulocytic type of acne, the onset is very sudden, usually 2 to 3 weeks, and then the patients develop nodular lesions already. And it may involve the complete face, particularly the chin, the cheeks, the forehead, and the nose. And just in case you want to do a biopsy, you will see a very dense infiltrate of lymphocytes surrounding the hair follicles. There's telangiectasia, um, as well as fistula formation. So this is one example. This is case number 10, a 24-year-old female with a sudden onset of nodules, cysts, papules, and pustules on the whole face. So when I saw the patient, I gave her azithromycin 500 milligrams 3 times a week for 6 weeks until most of the nodules, cysts, abscesses have subsided. And then I added low dose isotretinoin in her regimen. So this was the patient before and after treatment. So this is after 2 months of treatment. So the proposed treatment for rosacea fulminans is fairly new. So a pulse therapy of azithromycin 500 milligrams per day for 3 consecutive days, a week, or 3 times a week for a period ranging between 4 and 8 weeks. So during the World Congress of Dermatology in Milan, most of the lectures recommended the prescription of azithromycin on cases of rosacea fulminans. So the second most common underlying cause of maskne is actually yeast folliculitis, which is normally very common in tropical countries such as the Philippines. And the most common presentation is monomorphic papules and pustules. It is actually a yeast acne-form eruption. It is commonly and most often misdiagnosed as acne vulgaris. And the eruptions may be associated with increased population of malassezia or Pityrosporum flora, such as in immunosuppressed patients and those who are taking oral antibiotics. If you would like to do dermoscopy, you will see coiled loop hairs and hypopigmentation of involved hair follicles, suggesting invasion of yeast pores. And you will also see white clods, which correspond to pustules. If you would like to do a biopsy just to differentiate from either bacterial or inflammatory forms of folliculitis, you will see a dense infiltrate of lymphocytes surrounding the hair follicles. So this is the proposed treatment if you're dealing with maskne and the underlying condition is yeast folliculitis. So most of the time I notice that the patients don't respond to just topical antifungals. A combination of topical and oral antifungals is usually necessary. So I usually prescribe itraconazole 200 milligrams once a day for 1 to 3 weeks, may extend to 4 to 6 weeks. And this is the best studied treatment. An alternative medication would be fluconazole 300 milligrams for 2 doses, 7 days apart. Fluconazole is preferred because of its more variable bioavailability. Monotherapy, so please take note that if you do monotherapy with just topical antifungals, so the effect would be less. The addition of a keratolytic such as propylene glycol may improve the efficacy of topical antifungal treatment. So these are cases of yeast folliculitis or Pityrosporum folliculitis. This is case number 25, a 40-year-old female. She's a nun, also with psoriasis. So I gave her itraconazole 100 milligrams twice a day for 2 weeks with resolution of the yeast folliculitis. This is a case of a 46-year-old female who developed uh, papules and pustules on the mandibular area and the chin and the perioral area. Um, Monomorphic papules, some pustules. So I gave the patient also itraconazole 100 milligrams twice a day for 2 weeks. So this is for younger patients. This is how the lesions of yeast folliculitis appear. This is from a 32-year-old female. So the lesions are more prominent on the mandibular area as papules, pustules, monomorphic. Sometimes we call it a steroid form of acne because you see the same eruption when you apply a steroid cream for a longer time. So I gave the patient itraconazole 100 milligrams BID for 4 weeks, which was followed by isotretinoin 10 milligrams OD for 1 month with significant improvement. So this is another case, a 24-year-old female who I treated also with oral itraconazole twice a day for 4 weeks. So we can take note that just topical antifungal may not be sufficient for remission. We need to give the patient oral antifungals such as itraconazole or fluconazole. So acne vulgaris, most of you are experts already on the treatment of acne. So I will just discuss this very shortly. However, we should take note that for the diagnosis of acne, we should see open and closed comedones. So comedones are actually pathognomonic for the diagnosis of acne vulgaris. And acne most commonly affects adolescent or teenagers. Adults may develop what is called adult onset female acne, which is probably hormonal in etiology. If you would like to you play with your dermoscope, you will see a neutral yellow background, some arborizing like vessels, but you don't see the network of blood vessels that you see in rosacea. And if you do a biopsy for some controversial cases, you will just see a dense lymphocytic infiltrate surrounding the follicular infundibulum. So this is a case of maskne in a waitress, a 34-year-old female who developed comedones first. So you will see some closed comedones and some open comedones. And then she suddenly developed papules, pustules, and some nodules. So this is prototypical for acne vulgaris. I gave the patient azithromycin, although I gave azithromycin usually for rosacea fulminans, so 500 milligrams 3 times a week. And I started the patient early on low dose isotretinoin because she doesn't want scarring, or she doesn't want acne scarring. So this is the patient after 1 month of treatment with rapid improvement and resolution of the papules and the pustules. So this is one example. This patient is actually a nurse who wouldn't like to take oral medication. I wanted to give her oral limecycline. However, she doesn't want to take any oral antibiotics or isotretinoin because she plans on getting pregnant soon. So she was prescribed only topical clindamycin solution 1%. However, you will see a very slow or we don't expect a dramatic improvement with just topical medication. I noticed that in cases of maskne, even with underlying acne vulgaris, the patients would show only dramatic improvement if you give them both systemic and topical medications. Perioral dermatitis is very interesting. Until now, the exact cause or the pathogenesis has not been established yet. So clinically, the lesions appear as small papules and pustules. On the perioral area, there's underlying redness, there's pruritus. It involves women aged 18 to 25. However, in contrast to rosacea, there is no telangiectasia, flushing, or blushing. When I was a resident and in the books, it is written that the lesions usually surround the mouth and spares the vermilion border. However, as more and more cases of perioral dermatitis that I see, usually in some cases, it involves also the vermilion borders. It is less common around the nose and the eyes. And if you do a biopsy, you will also see a dense infiltrate surrounding the follicular infundibulum. You'll also see some multinucleated giant cells and some granulomas. So this is the proposed treatment if you're dealing with maskne with underlying perioral dermatitis. um, they respond to steroids. The patients respond to steroids initially. So topical steroids may temporarily alleviate a peri-orificial dermatitis. However, there are multiple reports, and most often, more expert clinicians would attest to this, that there is often a rebound when you stop treatment. So on the average, for patients treated with at least metronidazole, the time to curing was approximately 7 weeks. So the clinician and the patient have to be very patient with the treatment. And previous case series have reported success with metronidazole cream with a time to clearing of 3 to 6 months and 1 to 8 weeks. Oral erythromycin, other antibiotics which possess anti-inflammatory properties such as doxycycline or limecycline have also been considered as effective therapy for perioral dermatitis. A usual treatment strategy is a trial of topical metronidazole for 1 to 2 months and consideration of the addition of an oral antibiotic such as erythromycin if the rash doesn't resolve. Um, doesn't resolve. Other options, topical options include topical calcineurin inhibitors such as pimecrolimus or tacrolimus, sulfacetamide, topical steroids, and antifungal treatments are often discouraged because of incomplete resolution, longer rash duration, and possible rash recurrence. So this is just a patient showing um, a perioral rash, mostly of papules and pustules, and she developed the eruption 3 weeks after reporting to work using a surgical mask. So initially, I thought that the main underlying mechanism was allergic. So I gave the patient loratadine and betamethasone twice a day for 1 week and topical tacrolimus and desonide. So desonide in the morning and tacrolimus at night. So there was clearing after about 1 week, but then there was recurrence. So what happened was I shifted the patient on limecycline, 300 milligrams for 4 weeks, low dose isotretinoin at 0.01 milligrams per kilogram per day, and topical metronidazole cream for 0.75%. So after 4 weeks, I think there has been a 90 to 95% resolution of the rash. But I instructed her to refrain or avoid wearing surgical masks again. So only one out of the 30 patients developed seborrheic dermatitis. So you're all experts on sebderm. This is often accompanied by itching on the nasolabial fold. There's often scaling. I usually do dermoscopy on cases of seborrheic dermatitis where I see a pinkish background, dotted vessels characteristic of eczema, and yellow scales on surrounding the hair follicles. And if you do a biopsy for difficult cases, you will see a lymphocytic infiltrate surrounding the follicular infundibulum and some parakeratosis and some neutrophils on the shoulders of the follicular infundibulum. So this is the only one, the single case of seborrheic dermatitis with which developed after wearing masks. So this happened in a 17-year-old female, where I gave initially a combination, a fixed dose combination of oral betamethasone and loratadine, one tablet twice a day for 1 week. I asked the patient um, to just use a gentle soap-free cleanser, and I advised her to apply very thinly desonide cream on the red areas twice a day, and she has improved since. So, how do we avoid acne? So, this tips came from the American Academy of Dermatology COVID-19 Task Force and was published in the New York Times. So consider the type of mask you wear. Actually, the dermatologists recommend wearing 100% cotton, which allows the skin to breathe. But you have to make sure that the mask is very clean, similar to your underwear. That's what they are saying. And we have to advise patients to streamline their skincare routine. They have to use a gentle tensor, a fragrance-free moisturizer, and apply products with active. So for example, you just advise your patients to apply retinol only at night or tretinoin only at night and do not apply in the morning. And we can also advise patients to break up with makeup because most of the makeup actually clog the pores, and this will actually worsen the maskne, at least temporarily. And if our patients sweat, or if the doctors sweat underneath our mask, we can use micellar water or a gentle cleanser for a quick wash. So what is the conclusion of this brief talk or lecture? So what are the insights on maskne or acne mechanica from 1975 to our present observations? And I'm sure most of the experienced clinicians have more or less in India have more or less similar observations. So stress, occlusion, and an allergic or irritant contact dermatitis um, are actually responsible for the development of what is called maskne. So in 1975, Albert Kligman was already telling us that acne mechanica, or now maskne, can be just a local exacerbation of a previous skin condition, such as acne vulgaris, rosacea, and perioral dermatitis. And most of the time, just like from the case series in 1976, the acne mechanica is poorly responsive to just topical medications. And sometimes we have to give them systemic medications such as oral antibiotics. And now we can give the patients oral isotretinoin if the pathology is located in the sebaceous gland. The underlying condition should be correctly diagnosed and treated. So we have to examine our patients very well. We can do dermoscopy. Sometimes we have to do biopsy if the diagnosis is usually difficult. And then they have to be treated appropriately depending on the underlying skin condition. And then again, systemic medications are often necessary to treat maskne. And from the recommendations of the AAD, the mild and basic skincare regimen is often recommended. So before I end, I would like to thank one of my residents who helped me in this presentation, Dr. Ira Abelia, our first year dermatology resident, for this millennial type of presentation. So thank you very much again, Professor Thomas. I hope to see you in the near future.
Thank you very much, Dr. Ioannis. It's indeed very, very kind of you. I know it's very late for you in the night. Dr. Maya,
Yes, sir.
I think we can take up the questions for this session, and
Yes.
if he wants to go, we can.
Yes, sir. You have the question, sir. Can you take it over, sir?
Yeah, please, please.
Okay, sir.
I think the chairpersons have come in.
Okay, that's what I wanted.
Dhanlakshmi is in.
Okay, Dr. Dhanlakshmi, can you take over the proceedings, please?
Yes, please.
Dr. Palvin was also in, she said, I don't know how.
Can you see the questions?
I can see the question.
You want it?
Yeah, for the role of systemic steroids in acne, why certain acne patients say that their face is dry and some say it's oily. So for the first question, for the role of systemic steroids in acne, I remember when I was still a resident, especially for moderate to severe acne with nodules and cysts, before or when we start prescribing oral isotretinoin, we usually add systemic steroid. But then we noticed that in some patients, they become problematic, especially if you have withdrawn the steroids, then there's usually a rebound. So I think now in my clinical practice, instead of the steroids, I usually give the oral antibiotics first because of their anti-inflammatory activity. So like limecycline, oral doxycycline, and now I have been using a lot of azithromycin given 3 times a week just to control the redness and to control the inflammation. After that, I can, especially if the patient is a very good candidate for oral isotretinoin, if there's like potential for severe scarring and if we're dealing with nodular cystic lesions, acne fulminans or rosacea fulminans, and then I will give oral isotretinoin only at a very low dose. I usually don't give the regular 1 milligram per kilogram per day dosage. I think in the past we have used oral steroids, but now I think we have refrained. Most dermatologists have refrained from giving oral steroids in acne.
I think there's another question,
The-
Dr.
There certain acne patients say that their face is dry and some say oily. Now the patients would tell us that usually they have a combination of both dry and and oily skin. And I think it's part of puberty that the sebaceous glands have not yet developed are not yet very well developed yet. From Dr. Pundir, history of itch in yeast folliculitis, definitely the patient complains of itch, especially in the mandibular area. And if you check the upper chest and the upper back, you will also see this monomorphic lesions. And previously we call this steroid acne. because it's the same as the eruption in patients who have used as topical steroids for a long time. And we have to take note that the lesions are quite monomorphic with some pustules, and they usually develop a post-inflammatory hyper.
You're mute. I think, Professor Johannes, you're mute.
Dr. Johannes, yeah. Now you have unmuted yourself. No, again you're mute. Please unmute yourself. Yeah.
Yes.
Yeah, so for history of itch in yeast folliculitis, I think um, in majority of patients there is pruritus in yeast folliculitis, and I make it a habit to examine the upper chest and the upper back. If you see the same lesions similar to the lesions on the mandibular area, then most likely you're dealing with yeast folliculitis. It is also common among patients who are taking like oral steroids or inhaled steroids. So patients who are taking systemic steroids, patients with psoriasis who are taking oral methotrexate, they also develop yeast folliculitis. Very common among athletes and teenagers. So how do we differentiate yeast folliculitis and inflammatory acne? So when we see inflammatory lesions of acne such as pustules, papules, nodules, and cysts, we have to check whether there's presence of comedones, especially on the forehead, because the comedones is actually pathognomonic for acne. And you don't see comedones in yeast folliculitis. However, when we're dealing with younger patients, usually there's a combination of like acne, yeast folliculitis, or acne and rosacea. Yeah. Are there any other questions?
What is a low dose acne isotretinoin that you were talking about? How low is your low dose?
So what's published in literature is zero point 0.1 to zero point 0.5. So the starting dose is usually 10 to 20 milligrams a day. And we usually taper the dose once we have seen clinical improvement already. This is based on the recommendations of the AAD. So for example, the patient is improving after a month of 20 milligrams once a day of low dose oral isotretinoin, then we can taper to just 10 milligrams a day. For another month, if we see further clinical improvement, then we can taper to every other day. So this is actually also recommended by some of our Indian colleagues who have published recommendations on the use of low dose isotretinoin. I think most of the studies have been done by our Indian colleagues. But we have to give it for a long period of time. So instead of like the 6 months duration, sometimes we have to extend to 8 months to 1 year.
You request
Both of them are over here, Maya.
Yes, sir.
Dr.
Okay, sir.
Dhanlakshmi and Dr.
Dhanlakshmi,
Parveen are here.
can you just introduce the next speaker, and can we request Professor Johannes to stay back, or is it too late for him to stay back for the
Dr. Parveen is also in.
No, I'm listening to the other lectures because they're interesting. Yeah.
Oh, thank you so much.
Yeah, acne-form eruptions are my
An
favorite.
honor to
One
have
of
you
my
around.
favorite topics. Yeah.
Thank you so much. I think Professor Dhanlakshmi or Professor Parveen. Good evening, madam.
Good evening.
Ma'am, take over, ma'am. I think you have to introduce Professor Jacob Thomas for the next talk.
Yes, I have been listening to Professor David. Thank you very much. It was a very nice talk. How many male patients did you have?
Hello.
Am I
6.
audible?
Yeah, only 6 patients out of the 30. And only 2 patients were teenagers because, ma'am, they were not allowed. They are not allowed to go out yet because of the quarantine measures.
Okay.
So there's actually less cases of acne vulgaris.
Okay. Thank you.
And you'll introduce the next speaker, please.
Dr. Maya, shall I do?
Yes, please go ahead, or any of you, either of you.
The next speaker is Professor Jaikar Thomas. Yeah, he needs actually no introduction. He is very familiar to all of us. So right now he is the Professor Emeritus of MGR Medical University. He has a long, CV to be read. A very famous dermatologist of Chennai. I invite Professor Jaikar Thomas to take over the session.
Permit me to share my screen, please. My screen visible?
Yes, sir.
Right. Thank you very much, Professor Parveen, for making the introduction short and brief and meaningful. Now I'm going to make a presentation on hormonal acne. It's more a sort of creating a platform on which we could work on most of the cases of acne, particularly adolescents and females. So there'll going to be newer dimensions on which we're going to talk. I have to say that I have no conflict of interest. Now, these are some of the publications that I told you. I would like to create a platform and justify my presence here today and justify Dr. Maya's invitation to me. I've done quite a lot of work in acne. This is the Indian Acne Alliance work that has been going on for the last 5 years. And my colleague, Dr. Parimalam Kumar, and I, way back in 2013, published this really path-breaking presentation on hormonal acne leading to a paradigm shift in the management of acne. Now, I have to tell you, till such time, antibiotics were being used in a big way. We heard Professor Devi also talk about the use of antibiotics, but slowly I think antibiotics are taking the back seat. We did do a lot of studies when I was in the Balaji Medical College, particularly it was hormone-related study, and I thought I should say that finally culminated in a textbook of the acnes, again co-edited by one of the speakers today, Professor Parimalam Kumar, who helped me in a big way in compiling this book on acne. Now we know that acne is the most commonly encountered disorder with a great impact on the patient's quality of life. Patients and physicians are faced with many over-the-counter prescription acne treatments, and choosing the most effective treatment can be confusing. 90% of teenage boys and 80% of teenage girls suffer from acne. But what happens is, as they go into adulthood, it seems that a greater number of females suffer in adulthood. And it's unclear if the number of post-adolescent women with acne is increasing, or it is really because women are seeking the treatment more than what they used to in the past. I told you earlier I'm going to set the platform, and before we go headlong into hormonal acne, the pathogenesis would include a complex orchestration of biological signals in the pilosebaceous unit, and these are some of the pathogenic factors that we think about. And it's always topping the list of androgens. And of course, the sebaceous secretion, abnormal keratinization, Cutibacterium acnes, no longer known as Propionibacterium acnes. The name has changed recently. And surprisingly, the immune system is involved in a big way in development of the inflammation. And again, one more addition recently is the insulin-like growth factors, particularly the growth factor 1. Now, this is just to diagrammatically represent how it all starts off with Cutibacterium acnes and a cascade of events leading on to inflammation. But what is more important is, before even the Cutibacterium acnes starts working, is the androgen stimulation. It's androgen stimulation, and again, it is inflammation. In other words, I'm trying to tell you that it's the androgen stimulation and the other co-hormonal factors that are most important in the development of acne, and that's why all individuals do not develop acne. This is to correlate what was told earlier clinically, what is happening. What is happening biochemically, I told earlier, this is what is happening clinically. I won't spend much time on this because the global call came about 25 years ago when antibiotic resistance was reported. People getting worried about antibiotic resistance, and the dermatologists knew that we have to turn into a situation where we cannot just use antibiotics alone, because slowly most of the microbiomes which were sensitive to our antibiotics started developing resistance due to one reason or the other. Either it was due to improper use or inadequate use and so-called biofilm, etc. And eventually it was only the resistant bacteria that was surviving and thriving. And we heard, I think Dr. Maya asked about sub-antimicrobial dose. Now this sub-antimicrobial dose of doxycycline particularly is more of an anti-inflammatory effect than as an antimicrobial effect. And the recommendations state no more antibiotics as monotherapy. Cartloads of tetracycline used to be prescribed when I was a resident, but now nothing is being done. And the newer tetracyclines which are coming also don't seem to help in a big way. And therefore we come to rounding up the paradigm shift to looking at where the androgens are coming from and how we investigate for hyperandrogenism, number one. And the next reason for investigation is to start on treatment. When do we want to investigate in cases of acne vulgaris? Adult females with sudden onset and severe forms. Severe nodular cystic acne in adult females, particularly when it occurs the V of the face rather than the T of the face, that is along the mandibular border. Acne resistant to treatment, all forms of other treatment. The presence of hirsutism, because it could be part of polycystic ovarian disease, which I shall talk briefly about a little later. Women who come with history of irregular menstruation, it could be oligomenorrhea, and other cutaneous signs of hyperandrogenism, Now the sources of androgenism, whenever we talk about androgens, we should know from where they are coming. It's either from the adrenals, from the gonads, or from the skin itself. From the adrenals, as DHEAS, dihydroepiandrosterone, or androstenedione, which get finally converted to testosterone. From the gonads, in the case of males, from the interstitial cells of Leydig, and the ovaries from the luteinizing hormone, again, which get converted to testosterone, and eventually testosterone getting converted to dihydrotestosterone because of the alpha-2 reductase enzyme. Now, this is important again, differentiating alpha-1 from alpha-2, which I shall shortly tell you towards the end of my presentation. The 5-alpha reductase converting testosterone to dihydrotestosterone. Now, how does this increase in androgens take place? Different stages of life. During adolescence, when generally a little girl will come and say, this is my first acne or my first pimple, or the intake of androgens for diseases, or the diseases itself. And when we talk about diseases, it's mostly the congenital adrenal hyperplasia. And not to forget that genes rule. Genetic factors play an important role in the increase of androgens. What are the pathways of testosterone action? Again, I'm continuing to build a platform to go into hormonal acne. You have the gonadotropin hormones going in for the luteinizing hormone getting converted to testosterone, 5 to 7 milligrams per day. So we have different pathways. We have an amplification pathway, which occurs in the prostate as well as the skin. Quite often I tell that we have stolen multiple pages from the textbook of the urologist when we start treating acne. And even when we are treating androgenetic alopecia, is so true. Then we have a diversification pathway, which has got nothing to do with dihydrotestosterone, and that is mostly occurring in the bones and in the brain. And finally, an inactivation pathway, which takes place in the kidneys as well as in the liver. Now, what is the connect between androgens and sebaceous glands? Dihydrotestosterone as well as testosterone, predominant androgen stimulating sebaceous glands. They stimulate the sebaceous glands more and more of sebum is produced. See, DHT has 5 to 10-fold greater activity for androgen receptors. We're coming to androgen receptors again shortly because that's going to be the punch of the session today about androgen receptors. And sebaceous glands by themselves are going to play a role in the innate immunity, androgen metabolism, cytokines, and antimicrobial peptide production. So this is in short what is happening in acne and what are the targets of isotretinoin. We just spoke about the dose of isotretinoin, and we heard from Dr. Ioannis that they usually start with smaller doses. I start in very, very small dose, just 10 milligrams per day. So we know that isotretinoin can act as a comedolatic agent, it can act as a keratolytic agent, and by bringing down the inflammation, the microenvironment for the P. acnes or Cutibacterium acnes correctly are all reduced. And it's most important for us to realize that isotretinoin influences hormone levels in acne patients, particularly the total testosterone is affected. So we find that when we spoke about the pathogenesis of acne vulgaris, we spoke mainly of 4 factors, and all the 4 factors are brought about by reducing or excess use of isotretinoin. Now, once the decision has been made that we are treating hormonal acne, we are looking at individuals' hormonal acne, what is the type of the treatment and what are the options that are in front of us? We can use androgen receptor blockers or anti-androgens, either spironolactone or cyproterone acetate. Or we could inhibit the androgen production by the ovaries and the adrenal gland, making use of glucocorticoids. Somebody asked a question, when will you use the role of systemic steroids? Oral contraceptives, which can contain both estrogens and progestins, and drospirenone is an important drug which we use in women. Thyroid replacement, hypoglycemic agents because of the insulin-like growth factor are also important agents which will form options in hormonal therapy of acne. Then the inhibition of androgen metabolizing enzymes in the skin or on the surface of the skin. It's a future thought, but not very far away. The future is not very far away, which I shall tell you again during the end of it. The thrust is going to be on that. What are we going to investigate in patients with hormonal acne? What are we going to look for? Total testosterone, free testosterone, sex hormone binding globulin, everything, all this which I have mentioned here should be done whenever we suspect hormonal acne, because otherwise we are going to miss out on something. Definitely we are going to miss out on something. And these are some of the normal values, particularly the 17-hydroxyprogesterone. We should know anything above 200 could mean a genetic problem or a non-classical congenital adrenal hyperplasia. And all of them definitely refer to an endocrinologist. They deserve to be sent to an endocrinologist for being taken care of any other forms of tumor. And in the case of polycystic ovary, we've always been thinking LH FSH ratio, but now we know that that is no longer tenable. None of these are tenable. As a matter of fact, you take up the books, they all be mentioning about LH-FSH ratio, anti-Mullerian hormone. Anti-Mullerian hormone, again, but this anti-Mullerian hormone really does not indicate hormonal acne, but it might definitely, or a polycystic ovary disease, but definitely be a corroborative evidence when we are looking at suspecting polycystic ovary disease through an ultrasonogram report. And then the free androgen index is one thing which is important, which is calculated by total testosterone divided by the SHBG into 100. Values of more than 5 indicate cutaneous hyperandrogenism. So this will help definitely in our day-to-day practice when we really want to rule out polycystic ovary disease, because we find many of these young girls and who are really lean, they do not have other cutaneous features of hyperandrogenism. So in such situations, we'll be able to detect them at an early stage. I told you about the anti-Mullerian dose. Anything from 0.3 to 3.0 could be normal, and anything more than 3 indicates a woman with symptoms of polycystic ovary disease. However, this is not a final conclusion, my dear friends. Although all the other factors might be present, we should be able to see it in an ultrasonogram or echogenic evidence of polycystic ovary disease, which is included in the Rotterdam criteria. So oligo-ovulation and ovulation, other clinical or biochemical signs of hyperandrogenism, plus polycystic ovaries on ultrasound are defined by the presence of 12 or more follicles in each ovary. Or it could be an increase in the ovarian volume of more than 10 ml. So that has set the platform for hormonal acne. We know now that we are facing hormonal acne. We know how to investigate. We have come to a conclusion that we are now going to start treating hormonal acne. These are some examples of how we are going to. For a long time, LH-FSH was thought, this is an old picture of mine, where PCOD is compared with Saha syndrome. Now, what is the Saha syndrome? I'm sure the speaker after me, Professor Parimal Kumar, will be talking more on this when she's talking about acne-form eruptions. Saha just stands for seborrhea, acne, hirsutism, and alopecia, which can be seen very, very frequently. It's not uncommon at all. And I was telling you earlier about the V-zone acne that we could get in adults or adolescent girls, as against the T-zone acne, which you get in younger girls. The treatment, as I told you earlier, metformin, 500 milligrams BID. Don't be scared to use metformin. Don't be scared to use it. You use it 500 milligrams at least once a day. You'll find it to be very, very useful when you're treating adult acne, particularly hormonal acne. In addition to isotretinoin, we know that isotretinoin, again, is very, very useful against the hormones. It's got an endocrinological effect. And cyproterone acetate with ethinyl estradiol, available easily as Diane or Diane 35, along with topicals. Here's another example where it has been treated. I don't want to keep showing pictures and messing up the whole thing. Now, with regard to hirsutism, multiple cutaneous manifestations could occur, what we put together, and we tend to call them as cutaneous hyperandrogenism. Now, I told you earlier, for Indian women, 23 is the cutoff. When you look at the body mass index, usually we take it as 25, but one should remember that it's 23 for Indian women. Lean PCOS are metabolically obese. That's one thing which we have to keep in mind. Then I told you about the transvaginal ultrasonogram. DHEA is indicated when there is only acne without hirsutism. So don't be wasting the money and time of the patient by doing this. When there's acne without hirsutism, then we can do a DHEA. You can spend that money on doing a more valuable test like the anti-Mullerian hormone. Now, if spironolactone is used in less than 100 milligrams per day, investigations are not required in patients with hirsutism, PCOD, as well as with acne. You don't have to worry at all. Less than 100 milligrams we could use without any problem, just to show an example of hirsutism with acne. Different forms of combinations are available. Different forms of combination available with regard to estrogens and progestins. The combinations treat acne in adult women. It suppresses ovarian production of androgens, but you should not use it in women above 35 years of age. Do not use in women who smoke. It's a different international brand, but we have our very good Indian brands itself of Yasmin and Yas that's freely available, and with enough directions to the patient, we get good results. Now, does this androgen, we've been talking about androgen excess in women. Does it occur in men? Yes, it does. Yes, it does. And again, I'm sure we'll hear about the Apand syndrome, acne patterned alopecia with acanthos nigrians. I think we were some of the first to describe this Apand syndrome with acne patterned alopecia. That is your male pattern alopecia with acanthosis nigrians. They have described it in one of our articles way back in 2013. Now, what about diet, acne, and androgens? There's another thing we've always spoken about. How much of chocolates can an individual take? How much of milk? What type of milk? Is it Jersey milk or is it ordinary milk? Things like that. Now, it has been noticed that weight reduction improves insulin sensitivity and lowers serum androgens. And therefore, it's definitely going to improve the status of the sebaceous glands and bring down acne. And just to give you a series of what happens with high glycemic diet, increase insulin. Therefore, increase insulin-like growth factors, stimulates 5-alpha reductase, adrenals and gonadal androgen increases, the androgen receptor signal transduction increases, sebocyte proliferation is there, lipogenesis leading on to acne. So diet has definitely got a role to play in hormonal acne. Now, paradoxical observations are things which give us the problem. Because there are people who are here, I'm sure, among this audience who say, no, serum testosterone levels do not uniformly correlate with sebaceous gland activity. Another point is higher testosterone level in males with only slightly higher sebum production does occur. Females with acne with only slightly higher serum androgen trend with normal levels, as a matter of fact, do get acne. Then early onset acne in pre-adolescent girls with higher DHEAs but not free or total testosterone T levels. So what does that say? These paradoxical observations definitely draws us to a situation where all this while we've been talking about treatment of hormonal acne with combinations and permutations of hormones as well as with anti-diabetics, etc. So that brings us to a point that we are actually aiming at a moving target. We are dealing with a moving target, and it's going to be difficult for us to get at the target correctly. And for that, we have to know a little more about androgen receptors. So I told you earlier that I'll be talking about the androgen receptors. Now, this is also known as, in short, known as NR3C4, nuclear receptor subfamily 3, group 3, member 4. A type of nuclear receptor is activated by binding any of the androgenetic hormones, including testosterone and dihydrotestosterone in the cytoplasm, and then translocating into the nucleus. So this is the androgen receptor. We have a nucleus terminus and we have a cytoplasm nucleus. So from the cytoplasm, then it translocates into the nucleus. And obviously, this should have a genetic background, as I told you, genes rule. The main function of androgen receptor is as a DNA binding transcription factor that regulates gene expression. So no surprise or little surprise that there is definitely a genetic background for acne and these androgen receptors. Point mutations and trinucleotide. When you say trinucleotide, we mean the cytosine, adenine, and guanosine repeats. Now that is also seen in androgen receptor, just like what you would see in a DNA. We have already spoken about the use of spironolactone up to 100 milligram, very, very safe, doesn't need any investigations to act against dihydrotestosterone. Now, I introduced to you a new molecule, probably some of you would have heard about it, clascoterone, which acts against dihydrotestosterone by specifically inhibiting the androgen receptor. So we are not now, we are on a target which really going to help our patients with acne. We have a target at hand now. All this while we were aiming at a target which we were tending to miss. Clascoterone incorporates a four-ring steroid structure via four-ring, just like your cyclopentaphenanthrene ring, which you see in steroids, but is not a corticosteroid. Clascoterone exhibits ability to competitively occupy and inhibit androgen receptor activity. Now, usually androgen receptors, this represents the androgen receptor, this U-shaped. I've just made it like this, U-shaped. And dihydrotestosterone is known to go and fix to the androgen receptor. But our friend, the clascoterone, now blocks the dihydrotestosterone inside the sebocyte. So clascoterone competes with dihydrotestosterone binding with the androgen receptor, inhibits downstream signaling, which inhibits sebum production and reduces secretion of inflammatory cytokines. So we have with us now an androgen receptor, the first topical androgen receptor, which we thought going to be a future. That's why I said in my earlier slide, it's not very far in the future that we are going to start getting. Recently, I was told that it's coming into the Indian market, has been approved, of course, by the FDA, already US FDA. They're waiting for the DCGI to approve clascoterone. Now, here you find a little bit of biochemistry of it. Talking about it, I should be able to signify how much it really helps for us. It gets converted to cortexolone as well as cortexolone propionate by the plasma esterases. And there have been studies, phase 3 studies have already shown when compared with a vehicle, the investigator, the global assessment has been able to tell us that clascoterone is quite safe and it has good effect on mild to moderate acne with little adverse events. Winlevi is a brand that's available in the international market, which is prepared by Cassiopeia. Winlevi available is 60 grams, pretty expensive. I don't know how it comes into the Indian market, how much it's going to cost us. It's available as a 1% cream, FDA approved just recently in August 2020. Is to be applied as a thin layer on affected areas twice daily. So here we have a drug which is very, very safe. It's not going to have the adverse events of anti-androgens that we expect all this while and we are fearing all this while about. There are slight adverse events like stinging, itching, erythema, scaling in 3% of users comparable with vehicle. In the user vehicle also they got the same percentage of adverse events. So we have with us now a new molecule, clascoterone, 1%, which can be used as cream and very, very effective for acne vulgaris. And it's also going to be initiated in the use of androgenetic alopecia. So a few more slides only. Anti-androgens and acne. All acnes are hormonal. All acnes are hormonal. Anti-androgens are a natural choice in management. They are good team players. Please remember, they cannot stand alone as a treatment. They are not standalone medications. They are good team players. They also help correct other manifestations of androgen excess because we find so much of cutaneous hyperandrogenism coming up. My colleague, my resident and I had published a paper on that when about 2 years ago. So much of cutaneous hyperandrogenism can come down by using the correct combination of treatment. So rounding up the recent paradigm shift, the need to do an endocrine workup seems inevitable, particularly in women. Please do it, please do it. You're not going to be criticized for that. Forget not to think about the thyroid gland, please. And older methods are to be complemented with hormonal targeting, particularly in targeting the androgen receptors. So the need, my dear friends, is dermatologists who accept social responsibility and the need for a molecule, either systemic or topical, that is most effective and least irritant. And I suppose we will be getting clascoterone within a year's time. So messages would be, skin is an endocrine organ. Androgen excess is a rule rather than an exception in acne. Anti-androgens are a natural and logical choice in the management of all grades and all forms of acne. Androgens and sebum, what is the take home? Androgens and sebum are essential components for development of progression of acne over time. Androgen receptor inhibition is an important and clinically relevant mode of action in acne therapy. Glascoterone, which is going to come to India, 1% cream, is the first FDA-approved androgen receptor inhibitor for acne and proven to be effective and safe. Because after all this talking, the patient does not care about your science. What he or she wants to know is, can you cure him or cure her? That's all that he wants. All your science goes into the garbage bin at the end of the day. So we don't have to talk too much about it, but you and I, as specialists, should certainly know about this. So thank you very much, my dear friends. Thank you, Dr. Maya and Dr. Padmanandan. I think he's not been able to come for inviting me. Because the moment Dr. Maya told me this, I couldn't say no to her. I've been knowing her for more than 3 decades. And I couldn't say no to her. And I took this topic because it's one of those topics, again, just like psoriasis and atopic dermatitis, acne is another thing which is close to my heart, and I've done quite good amount of work. I shall be glad to take up any questions.
I would like to ask you one question. Which is the OCP you prefer, sir? The one with cyproterone or the one with drospirenone, sir?
Drospirenone.
Drospirenone.
For that.
Thank you, sir. Dr. Dhanlakshmi, any more questions?
Yeah. So far, no questions in the outbox. Dr. Janice is thanking Professor Sir for the very good, clear presentation.
Yeah, it was a very clear presentation.
Yes, thank you, sir.
Thank you, Dr. Johannes. Thank you very much.
There was a question, will topical benzoyl peroxide help in yeast folliculitis?
In treating what?
Will topical benzoyl peroxide help in yeast folliculitis?
I think this question is towards Janice, sir.
Johannes, yes.
Yes.
Can you hear?
The nascent oxygen being released by benzoyl peroxide, it might help as an anti-infective agent. Even in acne, we make use of it the same way. And with regard to systemic steroids, again, I wish to reiterate, there are only 2 indications when we are supposed to use systemic steroids. One is after starting isotretinoin, when there is an acute flare of lesions, to control it, you use systemic steroids. Number 2 is when you find heavy levels or higher levels of 17-hydroxyprogesterone, that is when you're dealing with congenital adrenal hyperplasia. These are the 2 indications which one should keep in mind for the use of systemic steroids.
Can we go on to the next, Dr. Dhanlakshmi?
Yeah, please. So no more questions at present.
Yes, you have to introduce Professor Parimalam.
Of course, Dr. Parimalam, recently known to everybody through our Middermacon 2020. She is, of course, known to me for more than 3 decades. And at present, she is holding the professor and HOD post of Government Stanley Medical College, Dermatology Department. And her CV also goes very long. To concise the time, I am stopping here and it is visible there in the screen. And now the screen is over to Dr. Parimalam. Please take over.
Good evening, everybody. Am I audible?
Yes.
Yes.
Sir, respected sir, Madam Maya ma'am, Dr. Dhanlakshmi, Dr. Ivanis, and all others who are listening. A very pleasant good evening and happy Saraswati Puja. Can I share my screen?
Yes, please.
Is it visible?
Yes, it's visible.
Yes.
Can you put it on slideshow?
Full screen. please.
Slideshow.
1 minute, 1 minute. Is it visible?
Yeah, it is, but not on slideshow, Dr. Parimalam. Just go to the bottom of the screen
It's
and
visible.
Yeah.
Make it full screen, slide view.
1 minute. It is.
Are you clicking on the icon, Parimalam?
Sir, I'm not.
at the bottom of the screen.
No, that is gone.
It's gone. You want to go back and come back again? You can
Close everything and again start sharing the screen.
Yes. Yes. Right.
Yes.
Yeah, full screen now.
Yeah, perfect.
Very good evening to one and all. At the outset, I would like to thank Professor J.T. sir for teaching about acne from the day I joined diploma in dermatology way back in 1988. So ever since we started learning dermatology, there has been a lot of change in both the concept and management aspect. Now I shall be sharing a few literature and few of my experience about acne-form eruptions. So acne-form eruption and acne, it is so easy to diagnose an acne vulgaris. Sometimes even the best of dermatologists will find it difficult to differentiate acne-form eruption and acne vulgaris, especially if it is in an acne-prone age, that is in the teenage adolescence. So the few things which will definitely help us differentiate acne-form eruption from acne vulgaris are: acne-form eruption occurs in any age, does not select the teenagers or acne-prone age, and the onset is invariably sudden. And the clinical feature which really helps is it has a monomorphic presentation more often than not, and there will not be any comedones. In acne-form eruption, they have mentioned papules, pustules, and sometimes even cysts and nodules. So this has a predilection for trunk more than face, unless and otherwise it is induced by topical corticosteroids or other oily base or cosmetic products or any cream. So there is no predilection for sebaceous area even in the face. So I'll just show you that. And as I mentioned earlier, nodules and cysts are not usually common presentation of acne-form eruption. So here, which I have been always wondering why, however severe the acne is, the periorbital and that 1 small centimeter of preauricular area is absolutely free in acne vulgaris, and sometimes it is also involved in acne-form eruption. So what are the causes of acne-form eruption? Sometimes the differential diagnosis and the cause do overlap. So I thought I'll make it very simple for me to classify. Predominantly, they are drug-induced. So we can just divide them into drug-induced acne-form eruption and those which are not induced by drugs. Of the drug-induced acne-form eruption, the steroids and OC pills are the topmost. And steroid folliculitis, in case you do a biopsy, you get a neutrophilic infiltrate. That indicates that there is a lot of inflammation inside that follicle infundibulum. And if you go to non-steroids, many drugs starting from our vitamin B12 to the most recent epidermal growth factor receptor inhibitor. Here we can see that cyclosporin is a double-edged weapon. It can induce acne, and in one kind of acne-form eruption like eosinophilic pustular folliculitis, that is the treatment. Similarly, dapsone. When we come to diseases, genetic, infection, hormone, metabolic, sometimes contact with chemicals and friction, which Dr. Ivanis was saying, friction. It is not only causing acne, it can also cause acne-form eruption and pressure. And whatever Sir was talking about syndromes associated with acne, sometimes definitely we do not make the diagnosis of acne vulgaris there. We just mark it as acne-form eruption, and suddenly when we see the associated findings, we know that it is a hormone-based syndrome associated with all the topical agents, which are, it should be specific. They're comedogenic or acnegenic. Comedogenic will not come in here because comedogenic induces comedone. But as per literature, acne-form eruption means there should not be any comedones. Even local radiotherapy can cause acne-form eruption. It can either be a papule or sometimes it can cause nodulosis also. So when it comes to infection, we have so many infective agents that can cause acne-form eruption, but as dermatologists, we see picrosporin folliculitis to be topping the list. The drugs causing acne-form eruption, it's a long list. Even B12, when you start giving B12 in certain individuals, within a week's time, 1 week or 2 weeks time, they might develop acne-form eruption and the immediately response within 4 weeks of stopping B12. So all the halogenated compounds that are iodized, anti-epileptic drugs, antipsychotic drugs, antitubercular drugs, growth hormones, cyclosporin, contraceptive pills, steroids, the list might increase as we go. And these acne-form eruptions, we cannot definitely go and tell the patient, take it again so that I want to prove. So it is only with the history and the clinical findings that we come to a conclusion that it is drug-induced acne-form eruption. Similarly, the causes and differential diagnosis, they overlap. Maybe here, the syndrome associated with acne, we know that they're all hormone dependent. But here, perioral dermatitis, granulomatous periorificial dermatitis, the variants of acne, rosacea, dermatitis, folliculitis, it is either staphylococcal folliculitis, gram-negative folliculitis, or pseudofolliculitis barbae. All these can pose difficulty in making a diagnosis when it comes to acne-form eruption. And sometimes, very rarely, lymphomas can present as acne-like lesions without comedones. And this is a picture of steatocystoma multiplex. For a beginner, it might look very much like acne-form eruption, acne, or sometimes we have to include it under acne-form eruption. So when you see a follicular lesion or a non-follicular lesion, see, these are all the non-follicular differential diagnosis. When it becomes non-follicular, invariably, we do not call them acne-form eruption. These are the follicular lesions which closely mimic acne-form eruption, or they are labeled as acne-form eruption until we go and do a biopsy and prove the etiological reason. So this is over the back. This lady is a 35-year-old lady. We do not expect truncal acne in a 35-year-old lady unless it is going to be a hormonal acne. But this lady was on ATT, antituberculous therapy. And this man, again, over the age of 40, you can see the acne scars, which is the telltale evidence of his acne during his younger age. But this man also had acne over the back. Sorry, I couldn't get the picture. And this man is on eptoin, that is phenytoin. So this is where we find it difficult to know whether it is acne or acne-form eruption. It is the history that will help in this boy. He says he has been applying topical cream from his friend's advice to become fair. I do not know how much more fair he will become. So that contained a steroid. And he says over a period of 15, 20 days, I was applying only 15 to 20 days. And his developed lesion invariably affecting the acne area. But then this type of a distribution, it is neither T nor V. So we have to take this as acne-form eruption, steroid induced, based on the history and the distribution. This man, when he came to my clinic, I thought he's got, as usual, either psoriasis or tinea or porous or something. He said, can I remove the mask? I mean, actually here we are not supposed to ask them to remove the mask unless it is necessary. I said, okay, remove the mask. And he had lesion only in the mask wearing area. So in our setup, we have to wear mask when you go out for our work or in the hospital. If you are at home, probably the contact time is less. For example, somebody working outside, they have to wear mask from 8 to 12 hours. So that is the reason why he got lesion only in the muzzle area. So I had another boy. I learned a lesson from that boy and I asked him to remove the mask, and I also wanted to rule out perioral dermatitis. So he has once again only mass. I do not know whether Dr. Ivanis will agree that these are all mass acne. And this boy was treated for acne, and he also took treatment for his scar. Now he's developed only pustules. This is all result of wearing mask, but then this is only a folliculitis which responded well to amoxicillin. So this, like this, at least I have seen some 20-25 men and women. All of a sudden they develop small pustules over the face, only over the face, nowhere else. So all these patients respond well to amoxicillin. I feel this is only sudden pustular eruption due to Staphylococcus aureus or Streptococcus, because within 2 weeks time they respond without scar and they become all right. So this is one, you won't believe, this is a staffness using betnavet. Sorry for me using the word, but on her own she's been using it because somebody said you use this cream, you will become fair. So this is acne-form eruption, and I had to convince her to stop. She said, if I stop this, my face will become dark. And this is yet another boy whose mother got him a steroid lotion because he had a rash over the back. So this is steroid-induced acne. And in case we are not very sure, there is no history, and they're not accepting that they've had any past treatment, sometimes we might have to go for a biopsy. And all that we see in such acne-form eruption is picture either like keratosis pilaris, where there is nothing except for follicular keratotic plugging, or you get to see a suppurative folliculitis, which can be either superficial or deep. If it's superficial, you see only neutrophilic infiltrate in the superficial area, and sometimes you see eosinophilic folliculitis. I'm not talking about OPG here. This is eosinophilic folliculitis in an acne-form eruption following either drug or cosmetic. And very rarely do we see granulomatous dermatitis and others like pityrosporum folliculitis. If we are lucky, we can see a positive CAS time. So B12 induced acne-form eruption, we normally do not think that we can be inducing acne-form eruption by prescribing B12. So within a week's time, at least less than a month's time, they come to us with sudden onset of acne-like lesions on the face. And if you check the B12 serum level, it goes very high. And if you do a biopsy, it shows eosinophilic folliculitis, not neutrophilic folliculitis. It shows eosinophilic folliculitis, and complete remission on an average within 1 week to 1 month to 1.5 months on withdrawal of the drug. So following radiotherapy, this is from the literature. By giving radiotherapy, sometimes there is acne-form eruption over the site of radiation. What happens is there is reduction in the sebum production, and there is alteration in the sebum concentration. I'm very happy that I was able to listen to JT sir's entire description of how the sebum acts and the chronic follicular inflammation. So if you do a biopsy, it will show hyperkeratosis, keratotic plugging, and hyperproliferation of the ductal keratinocyte. These radiotherapy patients, once again, within a month's time, they develop these lesions. And probably by the end of radiotherapy, if you're able to treat them, it becomes all right. And rarely, they also present with cysts and nodules, which is not a common feature of acne-form eruption. This is again from Dr. Zimo et al., who's presented only papular eruption following local radiotherapy. This is acne-form eruption following radiotherapy with cysts and nodules. This is during follow-up. This is not the main pathology. This is during follow-up of RT, which the biopsy did not show evidence of malignancy. All that it showed, this is post-treatment, all the biopsy showed was only ruptured epithelial cyst and the inflammation. So this is a new concept. I thought I'll spend a little more time on this because in days to come, many of our oncologists might refer these patients to us, because this epidermal growth factor receptor inhibitor is very frequently going to be used in solid organ malignancies, and we are going to see more number of skin problems with these drugs, because there is abundant expression of epidermal growth factor receptor in the skin and adnexal structures, and 80% of those who are put on these drugs will definitely show cutaneous manifestation. So the salient feature, what if even in iodide we see, even in phenytoin we see, but why are you so particular about learning the acne-form eruption of EGFRI treated patients? Because they are cancer patients in the first instance. Number two, these present with pain and pruritus. And there is cosmetic disfigurement, which is unacceptable. When it becomes very severe, it definitely impairs the quality of life, added to the cancer burden on them. And because of this, they might not be willing to continue on the cancer chemotherapy, when we have to tell them that it is important that you continue with this, and it might become all right as the days go, because it is supposed to be a surrogate marker of improvement of their health when they develop these lesions. So this is how it acts. It either directly inhibits the receptor, or through microorganisms, or through the inflammatory response. Finally, what it does is, it just alters the growth and differentiation of the follicular epithelium, causes keratotic plugging, ruptures the follicular epithelium, and of course we have the neutrophil influx. And in the biopsy, you see granulomatous pathology within the dermis. And if you do biopsy of the apparently normal looking skin, the pilosebaceous unit, which are atrophic, are seen there without the inflammatory infiltrate. So this will be the histopathological finding. You either get a superficial folliculitis or a deep folliculitis. If it is superficial, you just get minimal neutrophilic infiltrate. If it is a deep suppurative folliculitis, it just goes for a rupture of the hair follicle. So there will be epidermal atrophy, keratotic plugging, dyskeratosis, and acantholysis are also documented, with basal cell degeneration and lichenoid change. Invariably, we get a referral from our onco friends asking for a skin biopsy. Unless we know that these are the features of these lesions, we'll not be able to make a correct diagnosis that it is only due to this drug. And we should not be immediately telling them, please go and stop the drug, because to some extent, up to grade 3, grade 4, we can keep treating them. So the risk factors, as we know, that it is above the age of 70 years, and when you give more than one drug, that is combination therapy, this is more common. And we have to, and we have to know whether it occurs within the first 2 weeks. Supposing the patient is on therapy and he comes after 2 months, probably this is not the etiology. And this is how the lesions go. In the first week, there is dysesthesia. Next 2 weeks, they start developing papules and pustules, which crusts and leaves behind an atrophic skin with telangiectasia. So by 1 month, sometimes it stops, even though the drug is continued. For some, it continues. And for some, it can wax and wane. So unless we know in detail about this, we'll never be able to give proper suggestion to our onco friends. So this is how it starts. And if you grade them, if it is more than 30%, and the outcome is going to be very difficult. But then they say that if you develop cutaneous reaction to this drug, that means it indicates that the drug is acting and the cancer is responding. It can also get secondarily infected. They can go in for atrophy and added to cancer chemo. This skin manifestation definitely brings down their quality of life. So this is commonly used in cancer lung, colorectal cancer, and in pancreas. So now that we know that, it may be a surrogate marker for the efficacy of epidermal growth factor receptor inhibitors. We must know when to stop the drug. So these are the goals of therapy. When the beginning itself, we can decrease the inflammation. Sorry. You can eliminate secondary infection, prevent recurrence, and avoid other complications. So before you start on chemotherapy, start with counseling, and sometimes doxycycline can be started. And these are the individuals, and we have to definitely talk to them and tell them whether they can use topical corticosteroids, systemic antibiotic, even oral isotretinoin can be given if it is grade 3. For symptoms, they can always be given antihistamine, and if the prurite is so intense, we can even put them on gabapentin. So sometimes they start with 100 milligram of doxycycline or minocycline as we are starting them on chemotherapy. So the general preventive measures will be, as we do for our acne, prevent other skin irritants, use mild soap and shower oil. These are all only prophylactic. And this is how, in the beginning, it is enough if we use benzoyl peroxide and metronidazole. As the inflammation becomes more and the lesions are more, we can go for systemic doxycycline and minocycline. And if it is grade 3, you can go even for oral isotretinoin. Grade 4, when they can no longer tolerate the pain and pruritus and the lesions are worsening, we have to consider discontinuing the therapy or go for an alternate therapy. So this is not only a feature of adults, even in children, sometimes we get confused between acne-form eruption and childhood acne. Childhood acne is neonatal acne, but this can sometimes pose a difficulty. Childhood rosacea, childhood perioral dermatitis, and childhood granulomatous periorificial dermatitis. So these are the three rare conditions which can manifest as acne-form eruption in children, and invariably we do not do a biopsy. This is for academic interest. They only present as non-caseating perifollicular epithelioid granuloma. So to come to an end, this acne-form eruption, how we are going to manage overall? If it is drug-induced, we can stop the drug. If we cannot stop the drug and there is no alternative, just give keratolytics plus or minus moisturizer depending on the requirement, and then find out whether it is non-follicular or follicular. If it is non-follicular, think in terms of other diseases and not actually acne-form eruption. Assess other factors, and individual patient's prescription should be monitored weekly, because what we give today may not be continued forever without supervision. So treatment of acne-form eruption, you have to just withdraw the drug, except in EGFRI. Avoid acnegenic drugs in future and use exfoliant, antihistamine, antibiotic, antifungals, retinoids, benzoyl peroxide. This is a topical agent. Indomethacin, cyclosporin, dapsone are just given for eosinophilic pustular folliculitis. But please remember, this cyclosporin and dapsone, they themselves can cause acne-like lesions. So to summarize, acne vulgaris and its variants, fairly easy to diagnose. But monomorphic lesion, conspicuous absence of comedones, sudden onset occurring in any age, we have to suspect acne-form eruption. And not only that, we have to also think where all the conditions where such acne-form lesions can manifest, like in lymphoma. That is how we have to establish the cause. It can be from ordinary rosacea to lymphoma, where the patient can manifest with acne-like lesions, but the underlying disease is totally different. Similarly, from drugs, simple vitamin B12 to EGFRI, we have to elicit the history and stop the drug wherever possible, find an alternate drug, treat appropriately, and biopsy is definitely needed where we are not able to really fix our diagnosis. So with this, I profusely thank Dr. Maya for giving this opportunity, Professor JT sir for continuing to teach me, Parvin madam, and my friend Dr. Dhanlakshmi and Dr. Ivanis, who is still keeping awake to listen to our session. Thank you, one and all.
Thank you. Thank you, Dr. Parimalam. Am I audible?
Yes, madam.
Yes. My video is not responding. I don't know how. At least I could see the slides and hear Dr. Parimalam.
Yes, ma'am. I can see you also, ma'am.
Okay.
Madam, some
it's a very nice presentation.
Yeah.
Detailed and very advanced, latest advances, and what is needed for all the practicing dermatologists and PGs to know about acne-form eruption. Thank you very much, Dr. Parimalam.
Thank you.
There are some questions in the outbox. Shall I go to the questions, Dr. Maya?
Yes, please.
There is one question from Dr. Vijay Anand. Can we prescribe hormonal therapy as monotherapy in acne?
No, we should not. Always combine it with isotretinoin. But low dose of isotretinoin is good enough. I start with just 10 milligrams of isotretinoin, along with the hormonal therapies.
Thank you, sir. Thank you. The next question, Dr. from KP Kavita. Sir, is it necessary to calculate FAI, HOMA, IR every time in acne and hirsutism, or one day in therapy-resistant cases?
No. Whenever you find acne and hirsutism, it is best advisable to do your FAI as well as HOMA-IR, because you're going to decide whether you're going to start on metformin or not, on spironolactone or not. So when we want waiting such a decision, it's always better to do both FAI as well as your HOMA-IR.
Thank you, sir. Thank you. Next question is from Dr. Shakil Akhtar. Is there any relationship with insulin resistance and acne?
Lot of.
Yes,
As I
sir.
said, insulin-like growth factors are
Yes.
something which you have to. So insulin resistant. So many cases we start them on metformin. We start them on. Only thing is make sure that you review your cases correctly, because they are all kids, children, adolescents, and young adults. They must come to you regularly. Give some excuse and escape once they feel a little better. Metformin and all that, be very careful in using. But one thing is very clear in the use of metformin. I can boldly say that metformin does not cause hypoglycemia in a normoglycemic individual. Never ever known to cause hypoglycemia. If the individual is normoglycemic, you can use metformin, nothing happens. As a matter of fact, many of the girls who come to me and I start the metformin, they lose weight. They're so happy when they lose weight. They begin to lose weight, the acne disappears, the shape also improves.
Thank you, sir, for the extra advantages. Yes.
I'm afraid you're happy.
Thank you, sir. Next question from Dr. Hania Q. Khan. Roll up intranasal mupirocin in the management of maskne. I think this question is to Dr. Janice.
Yes, I think if the underlying etiology is Staphylococcus aureus and the eruption is recurrent, presenting with pustules and similar to recurrent furunculosis, then the patient will benefit with intranasal mupirocin as a preventive or a prophylactic form of management.
Thank you, sir. Thank you for the clarification. And next question from Dr. Sunita Thomas is, does anti-thyroid medications, example hypothyroid medications, help in hormonal acne? This is to Sir JT sir.
Anti-thyroid drugs are not given for hypothyroid states, first of all. You have to be careful in using that.
I think she means thyroxine or like that.
Supplement.
Supplement.
That maybe, that will, definitely, if there is an hypothyroid state, we have to give.
Thank you, sir. Then question from Dr. Shakil Akhtar. Topical of choice for acne-form eruption and truncal acne, which is the least irritant. Many complain of burning sensation and erythema with benzyl peroxide.
Professor Parimalam has to take this.
Yes, acne-form eruption and truncal acne. Yes, please, Dr. Parimalam.
I give salicylic acid with the short contact if they complain of burning. In the beginning, I tell them to use just 1 hour before bathing and then just see whether they develop burning. If they don't, because truncal acne, the skin is thick and some people can manage. If they're not able to manage, it is either a short contact therapy or alternative therapy. Salicylic acid, they're able to tolerate better than benzyl peroxide.
Dr. Maya, do you use selenium sulfide lotions for such individuals?
Yes, sir, I do, especially when they complain of itching, just 10 minutes before bath, at least for about a month. I also find that selenium sulfide decreases the post-inflammatory hyperpigmentation. So
absolutely. It's so useful. Only caution is we must tell them to use it on a moist skin. But very often what they do is over enthusiastically they just rub it on the dry skin. I have to ask them, go into the bathroom, wet your skin, then apply this. They expect a lot of lather to come. Tell them there won't be lather. There'll be only a sort of a soapy feel and a slippery feel. Wait for 10 minutes and wash it out. That's very good results. In 3 to 4 weeks, you get wonderful results.
And I start off with that 1% selenium sulfide, which is available now, so the serving daily, and then move on if they don't respond. It's supposed to be very useful for PIH, especially to prevent PIH.
Thank you, sir, and Dr. Maya.
I have something for Dr. Ioannis. What about this? You were talking about cleaning up the cosmetics before going to bed every night. There's a new product now which they keep talking about, detox pads. Do you all have any experience in the Philippines? Detox pads?
We don't have it yet in our market. What the women usually use are the oils, which are alternative to um, like gentle
Cleanser.
cleansers. Yeah.
There's one Dr. Paul Nassif, no, from US, who is promoting this
So
detox. Nothing.
detox
It only
pads.
contains alpha hydroxyacid and beta hydroxyacid.
All right.
That's
So
what we use
glycolic
in our
acids.
face washes for acne now. So-called hair glow and things like that, It's only alpha hydroxyacid and beta hydroxyacid which can be used. It gives it a different name, and a pack of 60 costs $45 US. That's pretty much high.
So micellar solutions are supposed to be effective, sir.
What?
And
Sorry?
micellar solutions,
Yes.
the only thing they're expensive.
They're expensive. And you have to differentiate SLR and SLR8. And that's another thing, Lauryl sulfate and laureth are two different things. One contains the micelles, the other does not. The loss of scope for treatment of acne and acne-form eruptions, one should remember that to keep your eyes and ears open, and we can keep using this. There's a question I can see, how long do we need to continue metformin in PCOS-induced acne? We might have to use it lifelong also, for quite a long time, but be careful about the potassium levels. Just because I said the blood sugar cannot come down, it doesn't become safe lifelong. When you're using spironolactone as well as when you're using metformin, be careful. Always monitor the patient. Cannot keep on giving them, for the rest of their lives.
I would just like to add on two things to your metformin question, sir. One, long-term metformin produces serum B12 deficiency. So I always wonder whether we should give B12 to these patients who are already coming to us for acne treatment. That is one.
After a point of time, maybe. Not
Yes.
immediately.
Not immediately. When you're saying lifelong, like PCOS. And number two is there is one product of metformin from India, which is supposed to contain that NMDA molecule. That's the reason it's been banned. So probably we should be aware of that particular brand and not use it. Probably use the safe ones of metformin.
Use a safe brand. There's so many brands, and a safe brand is there. All these things, you have to tell the gynecologist. They over enthusiastic do a little thing, without asking the dermatologist, particularly for the PCOD. There's so much of cutaneous hyperandrogenism. They should ask the dermatologist. They just do it on their own. By hearsay or by reading from the book, they start doing it.
And they give progesterones to make the acne worse. Instead of giving an OTP.
They should combine number one. Makes the acne worse, and there's so much of withdrawal bleeding. Clots and clots of them.
Dr. Parimalam wanted to say something?
If you're doubting whether that B12 is going to cause acne-form eruption, you can always test the serum level.
But how does the serum level indicate?
If the acne-form eruption, supposing you start the medication and the serum level is normal, and if the acne-form eruption worsens with your increased serum level, you know that it is because of B12. Unless the circulating B12 level goes up, you cannot say that it is because of B12.
There's one more question.
There are a lot of questions. ISO and doxy, is it contraindicated?
Yes, definitely.
Hypertension. Doxycycline is a thing which you have to, I don't think we should really be using doxycycline. Minocycline is a more helpful drug. Minocycline is supposed to be helpful, both as an anti-inflammatory agent also. Although our friend Layden is the one who, Jim Layden, a good friend of mine too, who has been writing articles on doxycycline sub-antimicrobial doses being useful as anti-inflammatory agent. But I really don't find them to be useful. And similarly, the lamicycline, which has come into the market in the last 2 or 3 years, It was there about 25 years ago. I'm not sure how many of you here are aware of it. Lamicycline was available earlier. Yes. It was in between stopped for a long time, and now the resurrection of lamicycline as a new molecule has come.
I would like to ask Professor Johannes, because he was mentioning about lamicycline. Is it better than doxycycline, or is that your first drug of choice?
I think the only benefit of lamicycline over doxycycline is the less gastric irritation. So the patients can usually tolerate it well.
Right.
Yeah.
So you start off with limicycline rather than doxycycline?
Usually, if the patient can afford, because limicycline is more expensive.
Yes.
If you ask any of my residents who have worked with me, they say this chap never uses antibiotics for acne. I have stopped using antibiotics for acne for more than 10 years, ever since I found them to be useless, number one, and then the question of resistance and all that. I'm so happy with isotretinoin, add on a hormonal therapy as and when required.
There's a question for Dr. Parimalam. Can you see it?
Is it steroid-induced acne-form eruption?
Yes, in COVID.
In steroid-induced acne-form eruption in COVID, no, this oral doxycycline is not going to prevent the steroid-induced acne-form eruption. And this steroid, they are not going to give lifelong, because only when there is a storm, that is leukotriene storm or inflammatory mediator storm, they're going to give, and within 2 weeks to 3 weeks, they're going to taper and stop. So it may not be required, and it is self-limiting, because we have been working in a place where we are seeing so many cases and we have not got a call as to start them on doxy.
But have you ever seen this with a cytokine storm treated with high dose of steroids? Do
it
they?
Is a protocol, sir. No, they do not, sir.
Do not.
That's what I'm saying. That is what I'm saying. We have not got a call so far that it is induced after admission.
Situation where steroid is required, definitely. You don't find so much of steroid-induced acne. For instance, you look at your pemphigus cases, your pemphigoid cases where you keep giving them steroid, you don't get to see them use developing acne-form eruptions, monomorphic.
Similarly, yes, sir. Similarly,
when they do start developing acne-form eruptions, it's for the clinician to think that enough is enough, my gentlemen, you have to now reduce the dose of steroid, you have to even stop it or go to an alternate drug.
Yes, sir. Similarly, cyclosporin, when we give for psoriasis patients, we don't see acne-form eruption. Whereas the renal transplant patients, they develop. It is just the duration that also matters.
It's the creator's phenomenon, no? Where when it's required for the human body, it doesn't have a side effect.
Yeah.
One more question. Topical sulfur soap for solutions for truncal acne. Are they effective? If yes, what brands are available in the market? I think, sir, topical sulfur soap.
Sulfur. No, we used sulfur years ago. When I was a resident, we were using sulfur topical, sulfur precipitate. Sulfur precipitate. I think even Dr. Parveen will remember. Precipitated sulfur with zinc cream we used in those days. But now it's all not useful. It's all gimmickry, which the pharmaceuticals tried to put on to us.
I think salicylic acid soaps or washes may be effective now, sir.
They are more effective. As I told you, alpha hydroxy acids and beta hydroxy acids are those which can be used. The thing is, they also take care of the pigmentation. And the post-inflammatory pigmentation that comes also is taken care of by alpha hydroxy acids. It's been a very interesting session.
Yes, sir. Can I just end it, sir? Can I just go with the my concluding remarks?
Please.
Good evening, friends. Today being Saraswati Puja, there can be no better way of celebrating it except learning dermatology from the derma gurus. My sincere thanks to Professor Johannes for giving us a detailed overview on this new entity called mask acne, as we are going to definitely see more and more of it in the future, as long as the pandemic is going to be there. We thank our dear Professor Jacob Thomas for highlighting new dimensions and treatment in hormonal acne. I also thank Professor Parimalam Kumar for giving us a very informative and lucid talk on acne-form eruptions. I extend my sincere thanks to our chairpersons, Professor Parveen Madam and Professor U.R. Dhanlakshmi, for chairing the session today. A very big thank you to all the delegates who have logged in on a Sunday evening, as this is the only thing that inspires us to conduct more and more webinars. And last but not the least, I would like to thank Dr. Reddy's for their continued support in this new normal. A very good evening and thank you all once again.
Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you all.
Thanks, Parimalam. Thanks, sir.
Thank you, all of you.
Thank you, Dr. Parveen. Thank you, Dhanlakshmi.
Thank you, Madam Parveen Madam and Dr. Dhanlakshmi.
Thank you.
Thank you, everybody.
Thank you, sir.